All right. Assalamu alaikum, everyone. My name is Rawad. I'm a fourth year medical student. And today, inshallah, we'll be doing the microbiology and immunology crash course from your Endo Repro block. So let's get straight into it. We've got four topics to cover today. The first one is genital discharge, and then we have genital ulcers, HPV and cervical cancer, and then finally, immunological processes of pregnancy. Now, this is all micro-related. These first three lectures are micro-related. So you may feel like there's a lot of information we're missing. That should be more for patho. Right now, we're going to speak mostly on the microbiology behind these diseases. So let's get straight into it. We have urethritis, first of all. Well, first of all, what I want you to remember is urethritis is mainly a sexually transmitted disease, and there's two extremely common pathogens, which are Neisseria gonorrhea and Chlamydia trachomatis. Now, when you hear of urethritis, most of the time it's going to be one of these two pathogens, and to determine which one it is, you have to look at the clinical signs, and very specifically, other than the lab features and obviously other than the actual culturing that you would do, other than the gram staining that you would do, you have to look at the color and the consistency of the discharge. That's really going to help you differentiate between gonorrhea and chlamydia. Okay, but in general, the clinical signs that you see with urethritis are obviously discharge. Dysuria is very important, and then frequency and urgency and any other lower urinary tract symptoms that you can see. And the risk factors, like we mentioned, is high risk sexual behavior, so multiple partners, no condom use, for example, or barrier contraception. And it's very common in adolescents and young adults. Okay, and this is an example of a gonorrhea, of urethral gonorrhea. And you can see here the gram-negative diplococci that are intracellular. Okay, and this is what the discharge would look like. With gonorrhea, it would look like sort of like a white, yellowish, thick, milky substance, whereas with chlamydia, it's more watery. Okay. All right, so here's a question. Which pathogen is associated with the following findings? So we have here a picture of some discharge. We have here what looks like to be conjunctivitis in a newborn or in a baby. And this is also more discharge, like cervical sort of discharge. So the answer is Neisseria gonorrhea. And again, we can see the sort of whitish, milky-ish substance. So here's another question. What's the diagnosis? And this is the same picture as before. The answer is ophthalmia neonatorum. And this is a which pathogen is associated. Obviously, we mentioned it before. It's Neisseria gonorrhea. This is an infective disease, usually with mothers who have some sort of gonorrhea colonization. And then when the children are born, when the newborns are born, they get this conjunctivitis. You could see here the sort of like the milky discharge again that we talked about with gonorrhea. Okay, so what's the gram staining of Neisseria gonorrhea? Gram-negative intracellular diplococci. This is very important. All right, intracellular diplococci. You have to remember that they're intracellular. Okay, and it's gram-negative. What's the management? Ceftriaxone. And obviously this applies not just to ophthalmia, this also applies to any other gonorrhea. So like gonorrhea, urethritis, for example, can also be treated with ceftriaxone. Okay. And what is the culture? What's the culture? It's Thyre-Martin culture. This is a selective culture for Neisseria gonorrhea. And what is it? It's a chocolate agar, and chocolate agar basically means that it's a blood agar, but the blood cells or the red blood cells are lysed. All right. And this usually happens when the like with intracellular pathogens that require nutrition from inside of the blood cells, you would culture them on a lysed blood agar or a chocolate agar. All right. And why do we call it thyromartin? Because it's selective to Neisseria and it contains vancomycin, colistin, and nystatin. This prevents the growth of other contaminants, other pathogens that may have contaminated the dish. Okay. And again, here are some other manifestations of gonorrhea. Again, this is Neisseria gonorrhea, urethritis, like we mentioned, cervicitis, endometritis, salpingitis, PID, which is very, very important for pelvic inflammatory disease seen in females. And then a complication of PID, which is tubo-ovarian abscess. And finally, ophthalmia neonatorum, which we talked about before. One thing that I want to mention is usually when you have gonorrhea in males, it's going to be it's going to be symptomatic. You're going to see the features classically of dysuria and urethral discharge. In females, it's not as symptomatic. It may be asymptomatic. And that just has to do with the female anatomy, the urethra being shorter, for example, or they're not necessarily if there's not too much discharge, then you really are not going to see too many symptoms. And usually males have more of the discharge symptoms and more discharge and more of the other symptoms that you see. How do you diagnose it? You could do a urethral swab and then you could culture that, or you could collect the pathogens themselves and then gram stain them, or you could do NATs, which are nucleic acid amplification tests. An example of that would be PCR. Okay, and again, this is a very helpful diagram. So Neisseria, gram-negative diplococci, metabolize glucose and produce IgA proteases. This is important. So they are gram-negative, so they do have not lipopolysaccharides, but lipo-oligosaccharides with strong endotoxin activity. That's why if you have bacteremia with Neisseria, this is very, very serious. Okay. And then there's here, it's just separating Neisseria gonorrhea from Neisseria meningitis. I don't think it's too important for you to know this stuff, at least not for this lecture, but you should know that it can cause gonorrhea, obviously, septic arthritis, neonatal conjunctivitis, which is what we saw before, a PID, and Fitzhugh-Curtis syndrome, which you don't need to know yet. This is, I think, something that you're going to take, or something that you might have already taken. I'm not too sure. Diagnosed with NATs, you could also, like we mentioned, do gram staining cultures and everything like that. All right, and you would treat with ceftriaxone. All right, let's go to the next slide. Let's read this. A 24-year-old man presents with a 4-day history of dysuria and mild urethral discomfort. He has noticed a small amount of penile discharge, most prominent in the morning, but denies fever, flank pain, or testicular swelling. He is sexually active with a new partner and uses barrier protection inconsistently. This is important. This is one of the risk factors that we mentioned. He's also a young adult, so this was another risk factor that we mentioned. Physical examination shows minimal clear urethral discharge without erythema or lesions. Testicular exam is normal. Urinalysis reveals leukocyte esterase positivity with increased white blood cells, but no bacteria are seen on microscopy. Now, this is clearly some sort of STI or urethritis because we can see the urethral discharge and we can see the symptoms of like dysuria and urethral discomfort. So this is urethritis. But they mentioned that we have minimal clear discharge and you cannot see any bacteria on microscopy. So what is this? This is NGU or non-gonococcal urethritis. Now, here's the important thing. Usually, when we have urethritis, we can split it into either gonorrhea or non-gonorrhea. And that's because the other pathogens that can cause urethritis, like chlamydia or things like that, they're not very well visualized on microscopy, and therefore they're not very like there rarely is an indication to actually go ahead and figure out the exact pathogen. And that's because most of the time, if it's not gonorrhea, it's going to be chlamydia. All right. So the way that physicians handle urethritis is that they're going to give most of the time just back or antibiotics to cover both chlamydia and gonorrhea. Okay. Now, what's the most common pathogen causing non-gonococcal urethritis? The answer is chlamydia. And what are some of the other organisms? We have ureaplasma, mycoplasma, and then the other two, which are very important, we'll talk about soon, Trichomonas or Gardnerella. All right, Trichomonas, you don't really see it in males or Gardnerella. All right, but they can cause urethritis in females, these bottom two. Okay. All right. So chlamydia cannot make their own ATP. They are obligate intracellular organisms. So this is partly the reason why they don't culture well and they don't gram stain well. Now, they don't gram stain well. That's because they don't have a cell body. So, or they, to be more specific, they lack the classic peptidoglycan in the cell body. So they're not able to gram stain very well. And they're intracellular. All right, so you have the elementary and the reticulate bodies, which I'm sure you remember from POD, but because of this, they're not able to culture well. So most of the time, they're not going to be well diagnosed, if that makes sense, or visualized. All right, so what do they call what can it cause? It can cause neonatal and follicular adult conjunctivitis. So it's another cause of the neonatal conjunctivitis that we spoke about before, NGU, PID, and reactive arthritis. It is more common than gonorrhea with PID. All right, so PID specifically more commonly caused by chlamydia than gonorrhea, although both can cause it. All right, it can cause some obviously some strains of chlamydia can also cause atypical pneumonia, but that's not what we care about right now. How do you diagnose it? PCR NATs. All right, so that's because it doesn't gram stain or culture very well. You can see the reticular bodies on Gemza or fluorescent antibody stain smear. All right, and what's the treatment? Doxycycline and azithromycin. All right, and read this here, add ceftriaxone if concurrent gonorrhea testing is positive. This is very important. So a very important piece of information is that a lot of the times when you have infection or sort of urethritis or an STI with chlamydia, you could see co-infection with gonorrhea or vice versa. Okay, so that's why when a patient presents and they have symptoms of urethritis, we would usually do ceftriaxone and doxycycline to cover both. Okay, now how do you tell the difference exactly? Both of them, both chlamydia and gonorrhea, the risk factors unprotected sex, although chlamydia can present a little bit later than gonorrhea. They all have very, very similar symptoms, although, as you can tell here, the discharge is going to be different. It's going to be abundant, yellow, and thick with gonorrhea, whereas with chlamydia, it's scanty, watery, and transparent, and it does have a foul smell. And the rest of the symptoms should be the same. So there's going to be burning with urination, although, again, more with gonorrhea. So just imagine, just try to remember that gonorrhea, all of the classic symptoms that you would see, you can see it in both, but more prominently with gonorrhea. Okay. In addition to the color and the consistency of the discharge that we talked about. Okay. Now I'll solve this. Which pathogen is associated with the following findings? Okay. So we see here something that looks like a strawberry cervix. That's a good way to describe it. These protozoa and this like kind of like greenish, frothy discharge, cervical discharge. So the answer is Trichomonas. So Trichomonas, what is it? It's a protozoa, obviously, and this is the life cycle of the protozoa. So it's only a sexually transmitted infection, and it's completely asymptomatic in males. So that's why if you get a patient, get a female patient who has Trichomonas vaginalis or Trichomoniasis, then you would have to also treat the partner. And what's the treatment? It's metronidazole. And how do you diagnose it? You're going to see these trophozoites, all right, on wet mount biopsy. And you're going to see the strawberry cervix, and that's because of it can also cause cervical edema. So it's going to be like a very puffy looking cervix with a bunch of these spots on them, and it's called strawberry cervix. Okay. And it has a very important to know that it has a greenish sort of discharge. And usually patients with Trichomonas vaginalis also have a high vaginal pH. Normally it should be low. If they have a high pH, vaginal pH, that also could be pointing to Trichomonas. Okay. And don't forget the greenish, frothy looking discharge. Okay. Very important. It says it right here. All right, who can tell me the diagnosis here? Here we have these are vaginal cells. All right, so this would be like this could be like a pap smear or something. These are vaginal cells, but you can see there's a lot of these tiny little bacteria on these cells. And this right here is again another picture of cervical discharge, but this time it looks almost like grayish and like very scanty, very watery. So this is BV or bacterial vaginosis. All right. Now, first of all, I wanna clarify the idea. There's sometimes a lot of confusion about BV, in that and the role of lactobacilli. So inside of the vaginal flora, there's this bacteria called lactobacilli, and lactobacilli prevents or sort of inhibits the growth of other bacteria that could grow in that environment. All right. If for whatever reason there is a loss or there is a decrease in the number of these lactobacilli, then you're going to get overgrowth of other types of bacteria and other types of pathogens. And we're going to talk about the most important one in the very next slide. But that's what I want you to remember about bacterial vaginosis. So these bacteria are not lactobacilli. It's actually this entire disease is caused by too little lactobacilli. Okay, so BV most prominently is caused by Gardnerella vaginalis. This is the bacteria. So it's a pleomorphic gram variable rod. So it doesn't gram stain well. Again, involved in BV presents as a gray vaginal discharge with a fishy smell. Very important to know the fishy smell. There's a bunch of, especially in this lecture of genital discharge, it's really important to know the buzzwords. So if you hear like strawberry cervix, trichomonas, green discharge, frothy, trichomonas, fishy smell, BV or bacterial vaginosis. Okay, very important. So it's non-painful, associated with sexual activity, but not sexually transmitted. Okay, because this is important. This Gardnerella is not, it's not a sexually transmitted disease, but one of the risk factors for it is a lot of sexual activity, and that's because you're losing the normal vaginal flora, which is the lactobacilli. So BV is also characterized by overgrowth of certain anaerobic bacteria in the vagina due to decreased lactobacilli. Um, Clue cells, this is what this is called, by the way. These are clue cells, which are vaginal epithelial cells covered with Gardnerella, have stippled appearance along the outer margin. So this is what it looks like. The normal Vaginal epithelial cells should just look like this light bluish cell without any of the dark blue spots around the edges. All right. And how do you diagnose it? We'll talk about it in a minute, but these three are part of a very specific criteria for diagnosis for BV, which are the amine whiff test, which is when you mix the discharge with 10% potassium hydroxide, and that will basically release the fishy odor smell. The vaginal pH is also high, so it's high in both BV and Trichomonas during infections, higher than 4.5. It's supposed to be lower than 4.5 usually. And the treatment would be metronidazole or clindamycin. Okay. So same treatment, by the way. So if you notice here, metronidazole, you can use it to treat both BV and Trichomonas vaginalis. All right, so what's the diagnosis? How do you diagnose it? You use AMSL diagnostic criteria. So it's you need three out of these four criteria. There has to be a thin homogeneous discharge, usually gray. All right, positive whiff test, which is the amine odor that's produced by mixing the potassium hydroxide with the vaginal discharge. The clue cells here, and a higher than normal vaginal pH. I don't want to say basic because greater than 4.5 would still technically be acidic. It would just be more basic compared to the normal vaginal pH. All right. And if you get three out of these four criteria, then 90% of the time this is a case of BV, bacterial vaginosis. All right. So who can tell me what the diagnosis is here? This is almost like a curdy, whitish discharge. It looks like they would describe it as cottage cheese. So this is vaginal candidiasis. All right. This is Candida. All right. Now the important thing about this lecture is to differentiate between Candida, Trichomonas, and BV, and we're going to talk about how in a minute. All right. But this is very, very classic for Candida. All right. Now, Candida, it's a fungal infection, obviously caused by Candida albicans. Now, what you need to know about Candida is that it's not necessarily as associated with sexual activity um, as BV, for example, or Trichomonas. It's more so associated with any sort of disease that's going to lower the protective function of the vaginal flora and uh, going to cause it to be susceptible to fungal overgrowth. So it's secondary most of the time, secondary to the use of antibiotics to treat a bacterial infection because it's going to kill the lactobacilli that produce hydrogen peroxide to protect against yeast overgrowth. Right? It's the same thing we mentioned. Other factors are as anything that can cause that. So pregnancy, obesity, diabetes, extremely important to remember diabetes. Okay, diabetes is a major risk factor for vaginal candidiasis. So are birth control pills. Okay, so oral contraceptives and diabetes, and you have a patient who has taken back antibiotics in the past, you're going to think, and now she's presenting with like sort of itchy vaginal discharge, it's going to be candidiasis. Steroids and poor feminine hygiene. All right, and you can split them. VVC, by the way, is vulvovaginal candidiasis. You can split them into uncomplicated or complicated. All right, if it's sporadic or infrequent, it's uncomplicated. Whereas if it's complicated, if it's recurrent vulvovaginal candidiasis, and that might be because it's a complicated case. Same thing applies with women who have candida, but it's not albicans. It's a different strain of candida that's complicated VVC. That's because the treatment would differ. All right, you wouldn't use what you would normally use, things like nystatin or fluoroconazole. You wouldn't use that. You would use some other sort of antifungal treatments. Okay, so how do you tell the difference now between BV, Trichomonas, and Candida? I don't want you to worry too much about this bottom row because we already talked about it previously. You're going to look at the texture first of all of the discharge. If it's thick, white, or curdy, and they describe it as cottage cheese, it's Candida. All right, and it's going to be white. There's usually no odor with Candida, and the pH usually is normal, so 3.8 to 4.5. And it's very important to know that it's very itchy. So out of the three of these, the most itchy would probably be Candida. All right, BV is going to be thin and like watery, milky, sort of grayish color. Going to have a fishy smell and it's going to have a high pH. Trichomonas is also going to have a high pH, but at this time it has a foul smell. So don't think fishy, think foul smell. And yellowish, greenish discharge that's foamy, you're going to think Trichomonas. All right. And what's the treatment for BV or Trichomonas, did we say? Metronidazole. All right. And for vaginal candidiasis, you could use nystatin, you could use fluoroconazole. There's a bunch of different treatments. All right. But just remember metronidazole for both, or clindamycin also for BV, I think. Okay. All right. Who can tell me what the diagnosis is here? You get these like grouped vesicles. Imagine that this is like somewhere in the genitals. All right. So these are like group vesicles, and then you do a sort of smear or you do a microscopy and you find these like multinucleated giant cells. So this is genital herpes. What pathogen? It's HSV1 and 2. A lot of people think that HSV2 is associated with genital herpes, but actually, recent studies have shown that both HSV1 and 2 can be associated with genital herpes, not just 2. Okay? Are the lesions painful or not? This is very important differentiating factor between this and other kinds of genital ulcers. These are very painful. Okay, so these ulcers, they are painful. These vesicles. Okay, how do you diagnose genital herpes? You could do NATs, which is one form of it would be a PCR, or you could do a Zenk smear. A Zenk smear is to see the multinucleated giant cells. This is an example of a Zenk smear. All right, and it's not just for herpes, it's also for varicella and other kinds of viral agents that are in the herpes family, herpes viridae family. All right. And how are they spread, or basically how are they, how do they spread from one person to another? It's through sexual contact and it's through scratching the vesicles. So these vesicles themselves are filled with the virus. So if you were to scratch them and one of them were to burst, that could also lead to spread of the genital herpes. Okay. What's the diagnosis here? So you get these little like ulcers, sort of these little lesions on the palms and soles. Uh, this is an example of a dark field microscopy, and you get these like necrotic sort of. I don't know if you can tell here, but this patient does have a lesion here, and it was sutured. So this is a necrotic sort of ulcer. So this is syphilis, and these are all like these two are different stages of syphilis. So you typically wouldn't see this. Like typically you would see this present, and then a couple months later you would see something that looks like this. All right, and this is just the dark field microscopy showing us the spirochete, which is Treponema pallidum, causing syphilis. Okay, so Treponema pallidum itself is a thin spirochete. It's corkscrew shaped. You can see here it's highly motile and it's too small for gram stain. So you do what's called a dark field microscopy. That's why everything around it looks dark. And how is it transmitted? Sexual contact or transplacentally, which can cause congenital syphilis, which I don't think we're going to talk about now. All right. So what's the pathophysiology? It's very important to know. These spirochetes themselves disseminate early via bloodstream and lymphatics, and they invade the endothelium. They're going to cause something called endarteritis, all right, obliterative endarteritis. And the arterioles themselves, the vessels themselves are going to be necrotic and they're going to be affected by these bacteria. And because of that, you're going to get ischemia and organ ischemia. And eventually that can cause the symptoms that we would see, like the gummas seen in tertiary syphilis and things like that. All right. You also are going to see plasma cell infiltration. So if you ever see a question stem describing obliterative endarteritis or like inflammation of the blood vessels with plasma cell infiltration, and in a patient who is maybe sexually active, then you might think syphilis. All right. And now syphilis itself can be split into either primary syphilis, secondary syphilis, or tertiary syphilis. Primary is just going to be the one genital ulcer. Usually it's going to be a painless, again, painless, it's not painful, painless genital chancre. Secondary is going to be obviously when it spreads through the bloodstreams and it's going to cause a systemic spread. So you're going to see um, the symptoms like fever, like arthralgias, you could see all these things, and it's going to cause rashes. So rashes and mucocutaneous lesions. You could also see something on the arms and the forearms, palms and soles. And then tertiary is going to be gummas, which are granulomatous lesions caused by these obliterative endarteritis and plasma cell infiltration. Aortitis, which can lead to aortic aneurysm and consequently dissection, and neurosyphilis. Okay, very important to know. So just to kind of zoom in on each one of these, again, syphilis caused by spirochete treponema pallidum, you treat it with penicillin G. This is very important to know. Okay, so primary syphilis is a localized disease, just one painless chancre. You use fluorescent or dark field microscopy to visualize treponemas in the fluid. All right, and then you get secondary syphilis, which is a disseminated version of the disease with constitutional symptoms. You get the rash, the maculopapular rash. It's going to look something like this. You're also going to see palms and soles, like sort of, they're called condylomata lata. That's what they're called. You can see them on the palms and soles. These little like lesions, sort of like ulcers. Um, and what else are you going to see? With tertiary syphilis, you're going to see these gammas. They're necrotic sort of ulcers, and the aortitis could lead to aneurysm and things like that. Neurosyphilis, and I really, really want you to remember the timeline of this disease. So painless, or sorry, primary syphilis is going to be around like 3 weeks after the exposure. Secondary would be weeks or months after that. And tertiary, you probably won't see it until months to years after the primary infection. Okay, this is very, very important to know. So if you ever see, because I remember I had this question once that sort of confused me. It was a patient who had a necrotic, this is the way that they described it. It was a necrotic ulcer on the penis. And I thought this was primary syphilis, but the word necrotic meant that it was actually a gamma, or it was, it's a tertiary syphilis. It wasn't primary. All right. So just keep that in mind. When they mention necrotic ulcers, it could be tertiary. It's going to probably most likely going to be tertiary syphilis. And this is what it would look like. Okay. And these two last pictures would be seen in congenital syphilis. We don't have to talk about it right now. Okay. Now we're going to talk about how you actually diagnose syphilis. So obviously you could do the dark field microscopy, but usually there are screening tests that you would do and then confirmation tests. So screening tests would be the VDRL or the rapid or and the RPR. They use them for screening and to monitor treatments. You could also do the anti-cardiolipin antibodies. So just remember these anti-cardiolipin antibodies and RPR and VDRL. They can have a lot of false positives. Now, if you get a positive results with either one of these, then you would do the confirmation test, which is the FTA ABS, which is like I think fluorescent treponema like antibodies. And these are again antibodies specific to the Treponema pallidum. All right, and they're going to remain positive for life. These are confirmation tests. And this is the nice little algorithm. So you screen it with a non-treponema test, so either RPR or VDRL. If it's non-reactive, then it's not syphilis. But if it's reactive, then you would confirm it. And obviously, then you could confirm the diagnosis of syphilis. Now, how do you treat it? Again, we mentioned it's penicillin G. There is this complication that could happen from treatment of syphilis called the Jerisch-Herxheimer reaction. And it's sort of just an immune-mediated, self-limited reaction. And it happens because when the penicillin is going to kill these bacteria, it's going to kill these spirochetes. The spirochetes are going to go on and release a lot of cytokines and a lot of things that's going to cause an immune reaction. And it's just an immune-mediated thing. It's self-limited. You don't have to treat the actual reaction that happens with penicillin G. Okay. All right. Now moving on to other kinds of genital ulcers. Here's where it starts to get a little bit confusing, and where it probably is going to be helpful to know whether an ulcer is painful or painless. So just to recap very briefly, we talked about in terms of ulcers, we only talked about herpes, we talked about syphilis. Syphilis, specifically primary syphilis, is going to be painless chancre. And herpes is going to be painful grouped vesicles. Okay, just remember that so far. Now we're going to talk about Haemophilus ducreyi, which is another word, which is the name of the actual organism. So it's a gram-negative coccobacillus, and it causes a chancroid. Now, what's the chancroid like? It's a painful genital ulcer with painful inguinal lymphadenopathies that are called bubbos. All right. And when you actually want to gram stain this bacteria, these Haemophilus ducreyi, is going to look like a school of fish. So they're all going to be like in a single fine line. It's called a school of fish appearance. And they're usually hard to culture. But the reason why we want to know if it's painful or painless, obviously, like we mentioned, is because we want to differentiate between different kinds of genital ulcers. So just remember, ducreyi, there's a very nice mnemonic that I found on Anking. Ducreyi for do cry, as in you do cry when you get Haemophilus ducreyi because it's so painful. So do cry, just remember that, do cry. And diagnosis is clinical diagnosis, and you could do a PCR just to confirm the presence of these bacteria, and you treat it with either azithromycin or ceftriaxone. Okay, and this is what it looks like. It's sort of like a ragged, purulent ulcer, very painful. So the ulcer itself is painful, and it causes lymphadenopathy, which itself is painful. Very important thing to know. So everything's painful with this disease. Okay, now the next one is called Klebsiella granulomatis, which causes donovanosis. And the reason we call it donovanosis is because this bacteria, which is a gram-negative bacillus, it shows up as these things called Donovan bodies inside the macrophages. So this is what it looks like. So if you were to look at a closer picture, I think it's on your slides, but it has sort of a bipolar shape where there's like almost what looks like a plug on either side of the bacteria. It's a very classic picture in your slides. I'm sure you'll see it. Um, and it causes something called a granuloma inguinale. And the reason we call it a granuloma what is because it sort of looks like granulation tissue almost. You know how granulation tissue, I'm not sure if you guys remember this from your inflammation lectures, I think in second year, but granulation tissue is very red because of all the angiogenesis. These ulcers are going to be painless, remember that, painless genital ulcers, and they're beefy red and they bleed very easily. So if you get a patient, a young patient, with a high risk sexual activity, for example, and they get this sort of ulcer that bleeds on contact, then you're going to think Klebsiella granulomatis or donovanosis or granuloma inguinale. All right. And there's usually no lymphadenopathy with donovanosis. This is what the lesion would look like. You can see it's beefy red and it has like a what looks like a lot of granulation tissue. All right. And how do you diagnose it? You could do a biopsy. You're gonna see these Donovan bodies. Again, you treat it with azithromycin. Okay. The next one is lymphogranuloma venereum, which is caused by chlamydia again, but these are different strains of chlamydia, specifically L1 to L3. This is what it's called. All right. And this is very important to know. I always get confused about this one. It's a painless ulcer, so the ulcer itself is painless, but it can progress to painful inguinal lymphadenopathy. All right. So do you see the difference here? The first one we talked about, which is Ducrei, painful ulcer, painful lymphadenopathy. The second one, painless ulcer and no lymphadenopathy, but it bleeds on contact. That's donovanosis or Klebsiella granulomatis. All right, now this one, lymphogranuloma or LGV for short, LGV, painless ulcer but painful lymphadenopathies, bubbos, and it can form draining sinuses. So itself, the ulcer itself can cause a sinus that drains is going to be very purulent discharge. Okay. Again, this is chlamydia, so you're not really going to diagnose it with a culture or with a gram stain. You're going to do NATs, which is what we talked about before, and doxycycline is the treatment, similarly to what we talked about before. Okay. So I hope we're all good so far. If you need to make a table, you can go ahead and do one. I'll show you a table at the very end that's going to be hopefully very easy for you guys to differentiate between all these ulcers. This is what it is, I guess. So we have painful ulcers up here, painless ulcers down there. Painful, so herpes, simplex virus, HSV, Ducrei, so they're large, deep ulcers with gray yellow exudates, severe lymphadenopathy that may suppurate. And then with herpes, it's small vesicles or ulcers on an erythematous base and mild lymphadenopathy. With syphilis, you're going to see just a single ulcer, which is called a pannus truncar, regular borders and a hard base. With lymphogranuloma venereum or LGV is going to be painless ulcers, small shallow ulcers, like we mentioned, but they can progress to form painful fluctuant adenitis. And the only one that I think is not mentioned here is just to make sure. Yeah, is this one. This is Klebsiella granulomatis, which are again beefy red, easily bleeding granuloma-like ulcers and with no lymphadenopathy. Okay. Again, this is another table just to make it easier for you. Just mainly look at the tenderness. HSV is tender, syphilis is non-tender, chancroid, which is the Ducrei, is painful, LGV is painless, but can cause painful lymphadenopathy. And with granuloma, painless also. Okay. All right. An ulcer caused by which of the following would bleed on contact? Take a minute, try to answer this. The answer is D. And then just try to think about what the rest of these are. So A is herpes, or HSV specifically. B is Treponema pallidum, seen on dark field microscopy. C is chancroid, which is Haemophilus ducreyi, the school of fish appearance. And D, you see the Donovan bodies causing granuloma inguinale. Okay. All right. So who can tell me the diagnosis is here? You get these like sort of cauliflower-like outgrowths. So this is condyloma acuminata. All right, condyloma acuminata, or some people say condylomata acuminata. And what pathogen is associated? It's human papillomavirus, specifically HPV 6 and HPV 11. All right, these are the low risk strains of HPV. Now, what's the type of tissue that HPV loves? You can tell from the name, papilloma. So, what sort of layer of the, or what type of epithelium can cause a papilloma? Squamous epithelium specifically. Okay. How are the lesions described? These ones specifically, flesh-colored, verrucous, cauliflower-like. This is condyloma acuminata. And then what's the associated malignancy and oncogenes associated with HPV? It's cervical cancer, and E6 and E7 are the genes. And what they do is they basically inhibit P53 and retinoblastoma gene and RB. And what P53 and RB does is that they're part of the regulators of the cell cycle, so they can cause apoptosis of any damaged cells, and they can also prevent proliferation. So it makes sense logically that if you were to inhibit both, you would get less apoptosis and you would get more proliferation, and that's what contributes to the cervical cancer. Very important to know. I think it's the next one. Yeah. What are the high risk types? So that's what I was going to ask. HPV 16 and 18. It's because HPV 16 and 18, they have E6 and A7 and E6 and E7 that are a lot more active than other strains of HPV. So HPV 6 and 11, for example, is only going to cause like these like genital warts that are seen with HPV, whereas other kinds, more high risk types of HPV could cause cervical cancer. This is very, very important to know. Okay. Now let's talk about HPV. So it's a non-enveloped DNA virus that infects squamous epithelium. We mentioned this before. You have low risk and you have high risk. So 6 and 11, as you mentioned, they can cause warts. I also want you to remember 2 and 4. 2 and 4 cause warts, but they do not cause genital warts. They more so just cause these warts that can be on your palm, for example, on your hands, anywhere on your body. These specific warts that are caused by HPV like 2 and 4, they're not called condyloma acuminata. They're called verruca vulgaris. Now, it doesn't mention this in your slides, but it is a piece of information that you're going to have to know for the future, so you might as well just know it now. All right, and what's the pathophysiology of HPV causing cervical cancer? E6 and E7. I like to think of it, and obviously E6 inhibits P53, E7 inhibits retinoblastoma. I like to think that like E6, or like the number 6 comes before the number 7, and the letter P comes before letter R. So 6 with P and 7 with R. All right, so E6, P53, E7, RB, retinoblastoma. All right, and what are the clinical manifestations of HPV? You can see condyloma acuminata, which are genital warts, coilocytes on pap smears. This is atypical cells seen on pap smear that could be an indicator of cervical dysplasia, which we'll talk about in a minute. I think you guys already took a lecture on cervical cancer, so you should be well aware of all of this by now. And recurrent laryngeal papillomatosis. And that's because your larynx, specifically your true vocal cords, are covered with squamous epithelium. And HPV loves squamous epithelium, so it can cause papillomatosis. All right, and the cancers, it can be cervical cancer, it could also be oropharyngeal cancers and anal cancers. All right. And how do you diagnose HPV? It can be a clinical diagnosis if there's warts, or you could do a pap smear. Now, a pap smear is something that you would do, and you would sort of brush off the top cells, the top layer of cells in the cervix and the endocervix to be specific. And from the pap smear, you could see these atypical cells called coilocytes. So you could see here, this is what a normal pap smear would look like. These are the normal cells of the cervix and the vagina. And if there's a lot of dysplasia that you can see here, this is probably going to be like this would lead to more like to further testing to know if this patient is infected with a high risk strain of HPV or not. All right, and how do you prevent it? You could do an HPV vaccine for all these types, type 6, 11, 16, and 18. And you could, the management, if it's, again, I'm not talking about cervical cancer here, I'm talking about generally in HPV. If it's just genital warts, you could do imiquimod or podophyllin toxin, salicylic acid, and you could do a surgical removal if there's needed. Obviously, if it was cervical cancer, there would be an entire different management for it. Okay, and this is testing. This is how you would do cervical testing. I got this from the latest guidelines that are linked in your slides. So women and other individuals with a cervix at average risk of cervical cancer should start screening at age 25 and continue until age 65. Now, how do you screen? You could do a primary HPV test on a cervical sample every 5 years, which is what's preferred, or you could do a primary HPV test done on a self-collected vaginal sample every 3 years, and you could do a co-test with a pap smear every 5 years, or a pap test alone every 3 years if HPV testing isn't available. All right, so we don't prefer to do, at least not these days, pap smear alone. Usually we would do an HPV test at the same time to detect if the serum itself has any HPV antibodies or HPV antigens in it. Okay, and this is the vaccination schedule. So from ages, there's a couple different kinds of the vaccines. Most of them would be either 2 or 3 doses. So this one here, for example, is 2 doses, 6 months apart from the first date, and it's age group 9 to 14. It's for females. All right. Again, you could do 3 doses that are within 6 months and everything like that. But the key date that I want you to remember is that age 9, that's when you could start. Some different resources say 11, so age 11 to 14. It truly depends, but that's when you would start in general doing HPV vaccinations. This one specific is for India, for example. A lot of different countries start vaccination. I think here in Saudi Arabia, we start at age 11. Okay. But it's the same thing, 2 doses, 6 months apart. All right. Now, moving on to the final lecture, which is the immuno lecture. The entire idea of the immuno lecture, of immunological processes of pregnancy, is that there used to be an older sort of theory for pregnancy, which sort of treats or acts like the pregnancy itself. It sort of um, um, at least we used to think that it resembles like a graft or a organ donation, wherein the immune system of the mother would have to be silenced or repressed in order to allow for pregnancy. Nowadays, we've learned that there's actually different stages of the pregnancy that are going to have specific cytokines and specific cells that are going to be predominant. And depending on the stage of pregnancy, it's either going to be a general pro-inflammatory state or a general like anti-inflammatory state. All right. So for example, in early pregnancy, when you have the sincero-trophoblast and the blastocyst that's sort of implanting into the uterine wall, and you need angiogenesis and you need all this sort of nutrition to go to the baby, it's going to be pro-inflammatory. This is an early pregnancy, and there's going to be specifically the most predominant cells are going to be the natural killer cells, and that's because they are going to promote angiogenesis, and they're going to allow for these bundle of cells, this blastocyst, to receive all of the nutrition that it needs to grow. Sort of in the middle of pregnancy, it would be a general anti-inflammatory environment. You're going to get these macrophages that are M2 and M2. They're going to secrete specific anti-inflammatory cytokines like IL-10 and TGF beta, HLA-G, these other human leukocyte antigens, just different things that are going to produce a more anti-inflammatory environment. These specific M2 macrophages have a specific name. We'll talk about it soon. And then finally, in the delivery phase, because we need the separation of the baby from the placenta, and we need contraction and we need all that stuff in order to expel the baby from the uterus, it's going to be again another pro-inflammatory environment. The M1 macrophages are going to be predominant. They're going to release all of these pro-inflammatory cytokines, IL-6, IL-1, interferon gamma, IL-17, TNF, all these things. All right. So just I want you to remember in different stages. So just think of it like, you know, pro-inflammatory in the beginning, and then in the middle, anti-inflammatory, and then at the end, and during delivery, it's going to be pro-inflammatory again. All right, now just to get a little bit more specific, in implantation, it's pro-inflammatory, so Th1, blastocyst invasion of the endometrium, and because of that, you're going to need angiogenesis, which are the job of the natural killer cells. So these are not the cytotoxic natural killer cells that we're used to. They're just natural killer cells. They're going to be secreting a lot of growth factors that are going to cause vascular remodeling. And then the macrophages are also going to secrete a bunch of cytokines like IL-6 and IL-8 and TNF alpha that are going to support implantation. All right, and this is what it would look like up here. All right. That trophoblast cell is going to secrete all these things. They're going to activate all these cells, and it's going to be immune cell recruitment and supporting the trophoblast invasion of the uterine wall, if that makes sense. Okay. Stage two is fetal growth. This is mid-pregnancy. This is, just like we mentioned in the previous slide, a anti-inflammatory state generally. So it's Th2 dominant. And I'm sure you guys remember the different kinds of T helper cells, Th1, Th2, Th17, all that stuff. All right. And then you get the T regulatory cells, which is tolerance to the paternal antigens and it's FOXP3 dependent. Now, the specific macrophages that I talked about before, the M2 macrophages, they're called Hofbauer cells. Hofbauer cells, they're M2 macrophages, so they're anti-inflammatory, and they're going to help with tissue repair and immune regulation. And then you're going to get these decidual NK cells that are going to maintain placental function, and the Th17 cells that are going to, for infection defense, and they're tightly regulated. Now, there's another very important thing that I want you to remember here. You guys remember HLA antigens, right? HLA A, B, C, all those things. Now, the mother's antibodies and the mother's immune system, they haven't been exposed to any paternal genes or any paternal antigens before. But the fetus does produce or does have these paternal antigens. And all of these antigens, all of these cells, they're going to have HLA, specific HLA antigens that are specific to the dad, to the paternal antigens on their cell bodies. So how come we don't get immune destruction of the fetus? Because again, the mother's immune system has not been exposed to these paternal antigens before. And the answer to that is in the next slide here. It's because HLA, the specific classic HLA, the classic MHC1 that's going to cause immune destruction is not expressed in certain parts, is not expressed in cells that are going to be exposed to the maternal blood. All right. So, for example, in the syncytial trophoblast, which is exposed to the maternal blood, there is no HLA-A or HLA-B, which is the classical MHC1. All right. And because of that, because there is no HLA-A or HLA-B, it prevents maternal T cell recognition. All right. But if, just hypothetically speaking, if in the syncytial trophoblast you had paternal antigens, then the T cells would go crazy and they would try to attack the placenta, and they could even try to attack the baby, and that's because there's some sort of T cell activation that happens. But again, they do not express these HLA antigens. Instead, they express HLA-C, E, F, and J, which are non-classical. And what these ones do is that they actually inhibit T cell cytotoxicity and NK cells. And because of that, it's going to prevent any T cell recognition and it's going to prevent T cell activation. This is the main idea that you need to know. All right. And also the natural killer cells, they bind with specific receptors on the HLA C and G antigens that decrease the killing of the natural killer cells and it increases growth factor release. So all of these, it's not just to prevent maternal T cell activation, it's also promoting the growth and the nutrition and the angiogenesis of the child and of the placenta and everything like that. All right. Some additional mechanisms is through production of PDL1, all right, which, if you remember, is a similar mechanism that's used in cancers and specific malignancies in order to suppress T cells. There's also this thing called endolamine 2,3 dioxygenase, which it eats up the tryptophan. You guys know that tryptophan is one of the essential amino acids that's needed for the body, and specifically for T cells. So it uses up all of the tryptophan so that T cells cannot proliferate as well. And again, this prevents, just like we mentioned before, T cell activation and attacking and destruction of the placenta or the fetus. And then back to stage three, where we talked about it's pro-inflammatory again. So we return to a pro-inflammatory state with NF-κB activation. And triggers are like toll-like receptor 4 activation, DAMPs, so the damage-associated molecular proteins and the surfactant protein A. You get the immune cell influx into the myometrium, and the cytokines that are released are what causes uterine contractions and eventually the expulsion of the child. Also is what helps with placental separation. Okay? All right. And again, this is another picture that shows of shows a sort of a summary that we talked about. In the first trimester, you get implantation and inflammation. So again, this is a pro-inflammatory state. And then you need Th2 type response in the second trimester because it's a general anti-inflammatory state to allow for growth of the fetus. And then finally, inflammation again to allow for the expulsion and everything. Now, this is a very, I love this table. I love this diagram, sorry, this graph. It shows us the levels of different immunoglobulin types in the newborn as soon as they're born and a couple months after they're born. So one idea that I wanted, well, we're going to look at these one by one. So first of all, you got IgG. IgG is the only immunoglobulin that can be spread transplacentally, and that's why it's so high at term. All right, but then it drops back down. So you'll see your IgG comes back down. So right here, this is the gestational age. You would assume that the baby is born right here. So you'll see it hits its peak right as the baby is born, and then after that, because there is no longer that um, placenta that's sharing all of the immunoglobulins with the mother, there's going to be a very sudden, very rapid descent of IgG levels in the newborn. And then again, at around 6 months, it's going to climb up again. That's because the baby is forming its own active immunity. All right. And this is another picture. This is IgG. I think this would be the fetal IgG. All right. You see here how it's climbing up. IgM, IgM is spread through or sorry, IgA is spread through breast milk specifically. That's why here you'll see it's steadily increasing. IgM is typically not very high in newborns, and that's because IgM is more associated with acute infections, but it would be high in the newborns if the mother was fighting some sort of infection during the pregnancy. All right, so for example, if you had an infection of toxoplasmosis, which I'm not sure if you guys remember, it's another protozoa, and the mother was fighting this infection during pregnancy, you could see high levels of IgM in the newborn right after birth. All right. Typically, it wouldn't be very high. You'll see here at birth, it's not very high. If it were to be very, very high, or at least higher than this level that you would normally see in newborns, then that tells you that there was some sort of maternal infection that was going on during pregnancy. Okay. So the main idea is that IgG drops right after birth because you had that transplacental spread of IgG, and then the baby starts forming his own active immunity. So then it's going to climb up again, sort of at around the 6 month period. So you'll see here that before 6 months, there is this period where the baby is very susceptible to specific infections, specifically if there's like encapsulated bacteria. That's because it doesn't produce yet the immunoglobulins that are needed to neutralize these pathogens, right? So very, very important diagram for you to remember. Okay. And I think, yeah, that is it. Here's the QR code for the feedback. Please let me know how I did, how I can improve. And thank you guys so much for listening. And please reach out if you have any questions. Thank you.